Okay. Good evening, everyone, and happy International Women's Day to you all. I am Dr. Maria Mohammed Bashir. I'm a PhD candidate at Institute of Public Health at College of Medicine and Health Sciences here at United Arab Emirates University. I would like to welcome you all to our health promotion webinar for today. This webinar is actually part of the global campaign, This is Public Health, and we are very proud to be affiliated with ASFA, that is the Association of Schools of Public Health in European region, which is an excellent collaborative network led by real public health pioneers. As part of this campaign, the Institute of Public Health, IPH, organizes monthly webinars where distinguished speakers are invited from all over the world to discuss topics of public health importance. These webinars are presented in both English and Arabic languages, and we hope you will continue to support us and participate in our health promotion webinars. So just a few housekeeping tips for today's webinar. We're going to have a presentation for about 30 to 40 minutes, followed by a Q&A session. And you are welcome to submit your questions during or after the presentation. So you can do so by clicking on the Q&A option in the middle bottom of your screen. And if time permits, inshallah, we're going to have an open mic questions at the end of the webinar. And we're going to have a link posted in the chat for the feedback form. Please kindly fill the form to receive a CME accredited certificate. So I'm very honored and privileged today to introduce you all to our speaker, who is Dr. Sabah Munib Al-Sheikh, who accepted our invitation to discuss a very important topic, which is titled Polycystic Ovaries versus Polycystic Ovarian Syndrome. Dr. Sabah is an obstetrician and gynecologist and a trained lactation consultant with the Ambulatory Healthcare Services, AHS, in Abu Dhabi here in UAE. She is a fellow of the International College of Surgeons in the United States. Dr. Sabah has received many professional awards and honors in both academia and her clinical practice. She received many recognition awards and appreciation certificates for the provision of exceptional healthcare services at Tawam Hospital and also at the AHS from 2014 to 2019. And in 2019, she also received the Best Physician Award at the SAHA Best 1000 Employee Award. She was also awarded by the Department of Health for her exceptional work as a frontliner during the COVID-19 pandemic in 2020. Dr. Sabah also held administrative offices, including head of obstetrics and gynecology department at a specialist hospital in Pakistan. Her publication, which is titled Hepatitis B and C, Value of Universal Antenatal Screening, was actually instrumental in developing guideline recommendations on hepatitis screening during pregnancy in Pakistan. She did her Master of Public Health MPH program here at UAE University and was given an award for outstanding performance both at departmental and college levels. She is currently an adjunct clinical lecturer at College of Medicine and Health Sciences here at UAE University from 2012 till date. Welcome, Dr. Sabah. We are very honored to have you here with us today, and we look forward to your presentation. And the floor is all yours now. Thank you, Dr. Sabah.
Dr. Sabah, we cannot hear you. Sorry, Mariam.
Yeah, we still can't hear you, Dr. Sabah.
If you don't mind, go back to the other option that we had, and I will share your screen. I will share your slides.
Okay, sorry for the little technical glitch. Okay, so Dr. Sabah is going to present on the topic polycystic ovaries versus polycystic ovarian syndrome, which I think today being the International Women's Day, it's actually a befitting topic because it is a very important issue to women. So the floor is all yours now, Dr. Sabah, if you're available.
Can you hear me now?
Yes, we can hear you. Thank you.
Okay. So I can hear the echo. Dr. Ifat, can you mute me?
I think, are you joining from two different devices? Maybe that's why. Close one of the devices.
Okay, fine.
Thank you.
Okay, so is it fine?
Yes, we can hear you.
Okay.
So no, sorry for this initial hiccup. My name is Dr. Sabah Sheikh, as introduced by Mariam, and I prefer to be called as like a woman health practitioner, as well as an advocate of women health education and support. Coming to the slides. First of all, let me just briefly explain to you, as it is a public health awareness activity. So we want all of the participants to be aware about the basics, and then we will gradually move onward to the more in detail, in-depth discussion about the topic. Women have two ovaries, each about the size and shape of an almond on each side of the uterus. Eggs, or the ova, which develop and mature in the ovaries, pass through the fallopian tubes and are released in the monthly cycles during the childbearing years. So you can see these two ovaries, they are almost the almond size, and these are a normal looking ovaries image. Can we go to next slide, please? Okay. Now, let us clear some terms which are sometimes mixed up or used interchangeably. First thing is ovarian cyst. So what is an ovarian cyst? It's a fluid-filled sac or a pocket, you can say, in an ovary or on its surface. An ovary may have one cyst or multiple, and which is not a normal finding. You can see the image on the left with the normal ovary on one side and an ovary with a cyst on the other. And this black and gray image is the ultrasound image. This is what we see on the ultrasound. So this is a typical ovarian cyst. Coming to the next slide. Now, what is polycystic ovary? It is an ultrasound finding of numerous small cysts, fluid-filled sacs in the ovaries. You can very well see the difference in the images in the previous and this slide. So it is small, multiple. The dimensions are usually 8 to 10 millimeter, and they are mostly scattered on the periphery. And because they are multiple in number, so we call them poly, because they are cystic, so cystic, and on the ovary. So the term used is polycystic ovaries. Now the thing is, what is usually confusing for the people is that they tend to mix polycystic ovaries with polycystic ovarian syndrome. So polycystic ovary is just this appearance seen on the ultrasound of numerous small cysts filled with fluid on the ovaries. The next slide. Now, this is what is polycystic ovarian syndrome. Polycystic ovarian syndrome is 3 of the features which are mentioned below. Polycystic ovaries, like I showed you in the slide before, presence of irregular periods, and features of excess androgens. So these three features are the ones which are making a part of a syndrome. One does not need to have all these features present. 2 out of these symptoms will be labeling our patient as a case of polycystic ovarian syndrome. So I hope it is clear that somebody may have polycystic ovaries, but may not have polycystic ovarian syndrome. And in some cases, there may not be any polycystic ovaries on the ultrasound, but like I said, 2 of the features out of these 3 can label an individual as a case of polycystic ovarian syndrome. So having irregular periods and excess androgens. Excess androgens, we mean the increased levels of testosterone and testosterone-like hormones, which can lead to the features of excess body or facial hair, development of acne. Menstrual irregularity can be in the form of irregular pattern, no menses for from the regular time, and there could be scanty menses, and there will be problem of the flow. Coming to the next slide. So the thing about polycystic ovaries is we don't know how many women actually have it, but it is thought to be very common. Our data from the UK study found that 1 in every 10 women in the UK are having it, but more than half do not have any symptoms. So because some of the symptoms are so mild, or sometimes they are not noticed by the person, that they just ignore it and don't come for further workup to know whether they are having polycystic ovarian syndrome or not. So what causes PCOS? This is a very common question, because whenever a person or when a lady is diagnosed with such a diagnosis, her first question is how I got it. What is the cause for it? Till now, the exact precise cause is not clear. There have been multiple theories, reasons, researches which have pointed to different reasons, but we'll be just discussing briefly the main ones which are thought to be responsible for leading to polycystic ovarian syndrome. Many women with PCOS have insulin resistance. What this means? That the body cannot use the insulin well. So this leads to the insulin buildup in the body. And as a result of this, this can lead to a higher androgen level. This leads to a whole like a chain of events, that is, obesity may develop, and which may further make the PCOS symptoms worse. One thing is also seen that PCOS runs in families. You may have a patient, individual who have PCOS, and when you inquire from them further, they will mention that their sister or mother and their daughters have the same features of irregular periods. So what are the symptoms of PCOS? So now we know that the causes are not yet clear, but yes, there is some genetic predisposition, there is insulin resistance, and obesity can occur as a result of insulin resistance, and insulin resistance can worsen because of obesity. So what are the symptoms of PCOS? Let's go to the next slide. They may include missed periods, irregular periods, or very light periods. The lady might complain that they come in time, but the flow is less than what I have noted before. Or she may say for months or 2 or 3 months. Sometimes we have girls who are saying for a year they are not having their period. So this can be one of the symptomatic presentation. Excess body hair, including on the chest, stomach, and back. We use the term hirsutism for this. Weight gain, especially around the belly. They may say that we are on diet and I am not a foodie. I have very good control on my food intake, but still my weight is just increasing, especially around the belly area. They may be complain of acne or oily skin, and there will be thinning of hair, and it's a typical male pattern baldness. That's the front part of the hair are becoming thinner. Some of the women present with infertility, or I prefer to use the term some fertility, that they are unable to conceive, and they may have some small pieces of excess of skin on the neck or armpits, the skin tags. They will be dark or thick skin patches on the neck, on the back of the neck, armpits. So these are some of the symptoms which usually alert the women to go and see a doctor. Sometimes they go to a dermatologist, sometimes they go to a dietitian, while in most of the cases, if they have menstrual problem, they come to a gynecologist for further consult. The thing is that usually they become apparent during the late teens or early 20s. So it is in the early young age that these features become prominent, and then they have to seek some help. On the next slide. Now, the PCOS just does not stop there with menses irregularity, with the hair fall, with acne. It can have long-term health problems like type 2 diabetes, high blood pressure and high cholesterol level, which eventually can lead to heart disease and stroke. Women who have had absent or very irregular periods, like 3 or 4 periods in a year for many years, have a higher than average risk of developing cancer of the womb lining, which we call as endometrial cancer. But the chance of getting endometrial cancer is still small and can be minimized further by using treatments to regulate periods. So we prefer any lady suffering from the PCOS not to remain without menses for more than 3 months, because the more she is in such a state, the more risk of developing this endometrial cancer. Diagnosis. Like I said, symptoms alert a lady to go and see a doctor, a dietitian, or dermatologist, depending upon what are the features which are more predominant in the presentation. When they're seen by a doctor, we do diagnosis using certain parameters on the basis of which we make this diagnosis. On the next slide, please, Dr. Ifat. Yes. So the most important thing is a proper medical history. And this medical history have to specifically inquire about the menstrual history. What is the pattern, the frequency, the flow, and the amount, number of days the bleeding continues, and since how long the pattern has changed, how she noticed it, and how long she has observed these changes, and what have been done about it so far. In a married woman, an obstetrical history is very important. Like I said, that many of these women can have infertility or subfertility. So obstetrical history is also one of the parameters to help in making a potential diagnosis, which can later be confirmed by certain workup to make the cause for such infertility. Also the family history, because there is some genetic predisposition also. Symptoms, as we discussed before, like the menstrual disorders, the androgenic features, and pelvic pain. Some of them have too much pelvic pain, and especially dysmenorrhea during the periods also. Physical examination is like you look at the general physique, the BMI, the weight, the pattern of hair, acne, hirsutism, and sometimes a pelvic exam is required, but now this is a rarity because we have other modalities to do our workup. So the tests which are done is an ultrasound pelvis, which is used to look at the size of the ovaries or the cysts. Like I showed you in the initial slide, a cyst is different from polycystic ovaries. So the ultrasound will tell us the shape and the size of the ovaries and the feature of the ovaries to help us distinguish between the normal, the ovary with a cyst, or a polycystic ovary. We also look at the thickness of the lining of the uterus, which we call endometrium, to see how much under the influence of hormones it is developed or undeveloped, depending upon the lack of hormones, which that's why in these individuals, they tend to have amenorrhea phases. The blood tests done are to check the level of androgens, like the male hormones, and other hormones, which are like follicular stimulating hormone, luteinizing hormone. We check for the prolactin levels and other features which are responsible, other hormones which are responsible for irregular menstrual pattern and androgenic features. We may also check the blood glucose level, cholesterol, and triglyceride levels, because the long-term effects of PCOS have to be arrested at this stage by finding the values of these parameters, so that we know where our patient is standing. After a PCOS is diagnosed, like I said, out of the three, any of the two, it's a diagnosis of polycystic ovaries. Sometimes the ultrasound will be clear, but the presence of history and presence of androgenic features, which is confirmed by the labs, is enough to make this diagnosis. So next comes the step of the treatment of PCOS. Till now, polycystic ovaries, what we know, cannot be cured. But the good news is the symptoms can be managed. Many of my patients who come to me and they ask me that, can we cure it? What I tell them is, you can manage it, and without it having affect your quality of life, you can live with it. Some of them have been going to different doctors, and you must be knowing, maybe from your personal experiences or the experiences of your patients or from your colleagues, that once they have it, they take some treatment, and then after some time, the problem comes back again. In the later discussion, we will see how it happens and why it happens. So yes, the symptoms can be managed, and the treatment options can vary, because someone with PCOS may experience a range of symptoms or just one. Maybe the issue is just irregular menses, maybe the issue is just androgenic features, acne, hair fall, or maybe the issue is unable to conceive. So we have to tailor-made the management according to the symptoms and according to the need of our patient. Treatment of PCOS depends on number of factors. The age, this is very important, like marital status. She's a married lady or a single girl. What is her age? What are the types of symptoms? What is the severity of the symptoms, and her overall health? It also depends on whether you want to become pregnant in the future, because the type of treatment we use have to be decided on the desires of the patient, whether she's planning to have a pregnancy in the near future or not. So we will be discussing the treatment options for PCOS. I'm just touching it in a very basic way, because this is a public health awareness webinar. But if you feel that we need to go more into depth, you can suggest, and then we can make another presentation with a more scientific approach for a particular group, basically those who are in the same gynecology field. But at this moment, I'm just touching it in a basic way to create awareness in our general population. So coming to the treatment options, we have medications. Many medicines are available. Let's go on the next slide and see. We have medicines to regulate menstrual cycle, to help in ovulation, and to reduce excessive hair growth. So like I said, we have to select medicine depending upon the symptoms, its severity, and the desires of our patient, what her plans are. So we select from this type of template what should be selected for our patient. Next slide, please. When the problem is of menstrual irregularity and our target is to regulate the menstrual cycle, we have option of combination birth control pills, or OCPs. These pills contain both estrogen and progestins, and they work by decreasing the androgen production, and they regulate estrogen, and they can help in regularization of the menstrual cycle. Having said that, remember, these are combined birth control pills. So I will not be selecting this for a patient who is keen to have a baby or is planning to have a baby. So that's why in my history, this part of the history is very important before I decide on the type of treatment to offer to my patient. The other option which we have to regulate menstrual cycle is the progestin therapy. Progestins are usually given for 10 to 14 days every 1 to 2 months to help regulate the periods and protect against endometrial cancers. Endometrial cancers develop because of unopposed estrogen for long duration, and that's why in these patients, we have to give progesterone support to nullify that effect of estrogen and not only regulate the menstrual cycle, but also to protect them from the long-term risk, that minimal risk of endometrial cancer. Now, if the patient desires to have a pregnancy and she wants my help as a doctor to help her ovulate and assist her in having a successful pregnancy outcome, then we have the option of a different group of medicines to help in that regard. Clomiphene is used. It is basically an oral estrogen medication and is given in the first part of the menstrual cycle to help ovulate and thus conceive. The other options are letrozole Femara, which is basically for the breast cancer treatment, but now is being used to stimulate the ovaries with good results for ovulation. Metformin, which is very popularly known as glucophage and is an oral medication for type 2 diabetes. And this has gained a lot of interest and good reputation in controlling the hormones of women with polycystic ovaries. It also improves the insulin resistance, which we discuss is one of the reasons or causes for the PCOS to develop. And thus it lowers the insulin level and overall the hormonal pattern also improve, which in a way leads to the regularity of periods and ovulation. If a patient, like we said, we have to check them for their sugars and cholesterol. So if you find them to be pre-diabetic, it can also slow the progression to type 2 diabetes and also helps with weight loss. As well as stimulating ovulation, encouraging regular monthly periods and lowering the risk of miscarriage, metformin can also have other long-term health benefits, such as lowering high cholesterol levels and reducing the risk of heart disease. So metformin is really have done a big, like you can say, a big change in how the polycystic ovaries is being managed. It is normally given for 6 to 9 months, and many of the patients are have reverted to normal patterns with the use of metformin. The other option is gonadotrophins. These are, of course, hormones, and they are given by injection under supervision to help ovulate and conceive and to help an outcome of pregnancy. The third reason, which usually the help is sought, is to reduce the excessive hair growth. For them, the medication options which we have is either the birth control pills, which decrease androgen production and thus help in reduction of hair growth, which is happening as a result of the excess of the androgens. Spironolactone, also known as aldactone, it works by blocking the effects of male hormones, such as testosterone, and some also suppress production of these hormones by the ovaries. So if the testosterone values are really high and there is too much of androgenic features, which are quite bothersome for our patient, then aldactone or spironolactone is a treatment of choice and can help in hair growth control. Spironolactone can cause birth defects. So like I said, know your patient. who you are treating and what are her desires. Like if she is planning pregnancy, you can see here, it's a no-no. Spironolactone causes birth defects, so not at all to give it to such women. And if they are married and have no desires for the pregnancies, but for her hair, then you have to advise her to use a proper contraception while taking this medication. Cosmetic procedures work very well. And in the meantime, while these medicines are taking effect, they can really reassure the woman and make her cosmetically satisfied with whatever her targets are. So the procedures which we have is threading, bleaching, waxing, electrolysis. Yes, laser treatment is now a very common practice, and it really benefits women suffering from excessive hair growth. The other option, surgery. Yes, there is some role, not that much now it is preferred, but yes, there is some role of surgery. Let's go on the next slide and see. Laparoscopic ovarian drilling. It's a minor surgical procedure by which a laparoscope is through an abdomen, in the small holes on the abdomen, is put inside the abdominal cavity, and we visualize the interior of the abdomen and the pelvis, and then the ovaries, which are affected by polycysts, we drill them to reduce their volume, and it is a treatment option for fertility problems associated with PCOS who are not responding to medicine. So like I said, it is not that much commonly used, but those resistant cases whom you have tried other methods for ovulation induction and you have found them to be unsuccessful, then this is one option which can be offered. The ovaries will then be surgically treated using heat or a laser to destroy the tissue, thus producing androgen. So you are burning that excessive area of androgen production. So in a way, you are decreasing the level of androgen in the blood. Lower levels of testosterone and luteinizing hormone and raised levels of follicular stimulating hormone happens as a result of this procedure. Follicular stimulating hormone, as we all know, this is the hormone which stimulates the follicles. So by increased levels of follicular stimulating hormone, ovulation can occur and we can achieve our target of ovulation. This corrects your hormone imbalance and can also restore the normal function of ovaries. So not only the hormonal balance is restored, the functions of the ovaries also come back. Those with PCOS must know, or those dealing with PCOS must be aware that PCOS is really something very annoying also. You treat yourself or you treat your patient, and after a while, they come back with the same issue. What I feel that despite that this treatment and everything, why it is coming back is that we are only focusing at that time on medicines and modalities and supplements and this and that. Lifestyle changes. Yes, this is the key. This is the main change which can control PCOS over lifelong. Yes. Remember, the foods we choose make a difference. Nowadays, those who are practicing gynae must be knowing that every day you see on an average 4 to 5 cases of polycystic ovaries with bad androgenic features, menstrual irregularities, unable to conceive, and other such problems. If you ask in the history, they have taken multiple treatments from multiple doctors and for so many years, and the usual statement given is that I took the treatment, I was fine for some time, and now the problem is back again. I tell my patients, when you don't treat the cause, the problem will keep on coming back. You cannot eat medicines all your life. Medicines are only for management of those issues, menstrual irregularity, hirsutism, to help in ovulation, but they will not cure the disease. How you can cure the disease, in a way cure the disease, is by the healthy choices you make. Let's come to the next slide and see. It has been seen that the symptoms and overall risk of developing long-term health problems from PCOS can be greatly improved by losing excess weight. Now, the thing is that losing weight in case of PCOS is not that easy too. It's really resistance. I mean, I can see how hard these girls try to lose weight, and really, sincerely, they try. They're quite compliant, but they don't lose easily. Why? First, because of the insulin resistance. Like we said, it leads to increase in weight and worsens the symptoms. And secondly, because the food which they are still taking unknowingly, that this is the reason that they are not losing weight. It's not about the calorie count. It is about the chemicals in the food, those juices, excess sugars, those chocolates, those junk foods. Some of my patients are saying they are, I mean, on a regular basis, drinking coffee from espressos and things like that. So although they are eating less, if you count what they are eating is less, but what they are eating is not healthy. So it's not about the calorie in the food, it's about the quality of that food. Is it really a healthy food or a chemically processed food? Weight loss of just 5% can lead to a significant improvement in PCOS, just 5%. And how much improvement you'll see, I mean, not even that much with medicines. We have to advise to maintain a healthy weight. Now, everybody, as per their age, as per their height, have a criteria for healthy weight, which we call as a basal metabolic BMI, which is calculated. And in that scale, we have to see what is the healthy weight for that particular person. And then we have to guide them and advise them how to maintain a healthy weight. We need big help from dietitians here. But apart from that, like I say, you cannot go to doctors all the time. You cannot take medicines all the time. The only thing, the best thing you can do to yourself is to eat healthy and live healthy. And definitely the weight will stay in the healthy range. Limit carbohydrates. Low fat, high carbohydrate diets might increase insulin levels. So not too much of those carbs. Yes, be active. Now the be active part is nowadays quite inactive because we have all become quite sedentary, especially with this new technologies in our hand. So be active should be really actively taken into consideration. Should exercise to help lower blood sugar levels, increase daily activity, and increasing daily activity and participating in regular exercise programs may treat, yes, or even prevent insulin resistance and help keep weight under control and avoid developing diabetes. So it's not just your PCOS, it's not just your hormonal levels, it's for your long-term benefit, your diabetes, your hypertension, your cholesterol. So if you have a lifestyle, a healthy, active lifestyle with a healthy eating habit, will definitely pay you over the years. So just conclusion. Like I said, no cure for PCOS. Sad. I'm sorry to say this, but yes, what we know as of now, we have to understand this and just come to terms with it. But like we have discussed in our previous slides, it can be treated, it can be managed. PCOS and overweight. Losing weight and eating a healthy, balanced diet can make symptoms better. Medicines are also available to treat symptoms such as excessive hair growth, irregular periods, and fertility problems. If fertility medicines are not effective, we have simple surgical procedures called laparoscopic ovarian drilling, and other, like wedge resection is no more recommended, but laparoscopic ovarian drilling can be. So this is a brief outline that what can be done for PCOS and how you can manage PCOS with medicines and with surgeries and with weight reduction. But the secret is in the next slide. PCOS is not a disease. Yes, it's mainly a lifestyle disorder. The earlier this is understood, the better the PCOS is managed, the better is the outcome. You avoid taking medicines, you avoid unnecessary stress and anxiety. It's not a disease. It's our lifestyle, our unhealthy lifestyle. Very few cases of genetic PCOS, very few cases. Mainly it is that new modern era lifestyle that we see PCOS so frequently. The keywords for PCOS, if you want to manage it forever, work out, eat well, and be patient. Don't expect miracles that I have went to the gym for the last 1 week and things are not back to normal. I'm eating well for the last 1 week and I don't feel a difference. Be patient. You will see results. It may take 1 to 3 months, but believe me, I have seen it in my practice. I have seen it in my patient. The results come. So the PCOS, the other modalities of management is just to symptomatically satisfy or improve the patient. But the mainstay of PCOS is make lifestyle changes. Thank you.
Thank you very much, Dr. Saba Al-Sheikh, for this excellent and very comprehensive presentation. Actually, you've covered all aspects of the topic, especially the management strategies. And I really like your final quote that PCOS is not a disease, rather it's a lifestyle disorder, especially since you emphasize that making healthy lifestyle changes actually is the key or the mainstay to control this disease. So thank you very much for that. And now we have the floor open for questions and comments. Please, if you have any question, you can, or you can raise your hand. Okay, I think there is somebody raising their hands.
Okay. Yes, yeah. You can give them the option to speak.
Okay, okay. Sure. So I think Nadir.
Yes, Assalamu alaikum.
Alaikum assalam.
Thank you very much, Dr. Saba. I'm Dr. Nadir Mustafa Na'ma Clinic. Really, it is very interesting lecture and very comprehensive and very easy to understand for everybody. Thank you very much for that. My question about the how percentage nearly for the people of PCOS having conception problem, and what is the rate of success with medical treatment in relieving this problem? Thank you.
Thank you, Dr. Nadir. The thing is, like I said, that many of the people, women who are having PCOS are not even aware about it. Now, as for the statistics, we don't have specific statistic that these were the individuals who had ovulation issues because of PCOS, and then they were treatable and then they were not treatable. At the moment, I don't have such statistics, but what we know that majority of the women undergoing assisted reproduction techniques are mainly for the reason of ovarian insufficiency as a result of polycystic ovaries.
Dr. Mariam, unmute, please.
Thank you very much.
Okay.
Yeah, I think it's Pastaki raising their hands. Please go ahead and ask your question. Sorry.
Yeah, sorry, I came a little bit late. I just want to know the difference. I came for a second part, but I missed the phosphate part for PCO versus PCOS. So please, could you clarify again? I came a little bit late.
Okay, that's fine. Okay, now the thing is PCO is polycystic ovary. It is an ultrasonographic feature, which means that the ovary have many small cysts. So we call it polycystic ovary. Just an ultrasonographic feature. To call it a syndrome, it should have some additional symptoms like menstrual irregularity or androgenic features. There are three symptoms which comprise of polycystic ovarian syndrome: polycystic ovaries on ultrasound, androgenic, and menstrual. Having said that, one does not need to have all these of three present. Any of these two makes the diagnosis of polycystic ovarian syndrome. So maybe the patient does not have polycystic ovarian appearance on the ultrasound, but have menstrual irregularity, have androgenic features. This is enough to label it as a case of polycystic ovaries, which can later be confirmed by blood investigations of hormones. So sometimes the patients are coming and they say, we did a scan in the private and they told me I have polycystic ovaries. So our next question is to ask them about their menstrual history and to ask for symptoms like androgenic features. If no such thing is present, cycles are regular, no androgenic features, so just the appearance of polycystic ovaries on ultrasound does not label that patient as a case of polycystic ovarian syndrome. I hope clear enough.
Oh, that's very clear. Thanks very much, doctor. Thank you.
Okay.
Okay, thank you, Dr. Sabah. There's another question for you from Zulfishan Alam. Thank you for this enlightening talk, Dr. Sabah. My question is, if ovulation pain that occurs in some women can be related to PCOS too?
Yes. If you remember in our initial slide, when we're talking about the symptoms, one of the feature is pelvic pain. What actually happens is that because of the polycystic ovaries, the ovaries are a bit heavier. So especially at the time of menses, when there is more of the pelvic blood flow, there's further increase in heaviness in the pelvis, and they tend to feel more pain during periods, apart from some of them feeling pain at other time of the cycle also.
Thank you for that. There is also another question from Fatma. She's saying, thank you, Dr. Sabah, for your great presentation. Do you recommend repeating HbA1c level and lipid profiles regularly for women with PCOS? And do we need to get OGTT or an HbA1c would be enough?
Okay. PCOS have long-term risk of developing diabetes, hypertension, hypercholesterolemia. So if at least one workup should be done on all these individuals. And if you find that workup to be normal, then you can follow as per the guidelines you follow for such patients in your CDC clinics or your diabetes or hypertension clinics. But at least one workup should be done to filter out who are the potentials who need more vigilant and more regular investigation and workup plus intervention, so that they do not grow and develop into a full-blown case of hypercholesterolemia or diabetes.
Okay, thank you. Please, you can still go ahead and type in the Q&A or the chat box. So while waiting for the audience, I would like to ask you a question too, Doctor. I want to know, please, in UAE, in your own opinion, like how common is PCOS? In your clinical practice, like how often do you see patients diagnosed PCOS?
Okay. On average, I see around 15 to 20 patients per week in my own practice, and the age group is as young as 14 years. And really, it's like, to me, it's looking like in a day, like every other patient is a case. Either a new diagnosed case of PCOS, or those patients who are already diagnosed and now are in follow-up with me.
So what do you think, in your opinion, like what are the research gaps that we have in UAE in relation to PCOS? Is there anything that you think we need to explore more on the topic?
Yes. Even I was discussing lately that we need to work more on lifestyle modification. I'm more of a conservative doctor. I am not a pro-medicine doctor. And this has further been strengthened by the results I have seen in my patients. And believe me, that when you tell somebody that this thing can be managed with just lifestyle modifications, you can avoid hormones and you can all your life have a healthy life. Just avoid these junk foods, this lifestyle which we are living. A patient today told me she sleeps at 6 in the morning and wakes up at 2 in the afternoon, and her eating system is totally. So this is why we are having more of lifestyle changes which are leading to more to PCOS. So I think we need to do some studies here to see just the effect of lifestyle modification on the levels of hormones and the symptomatic improvement.
Thank you. There is someone raising their hand. Rasha, please go ahead and unmute.
Hi, I just wanted to ask a follow-up question in terms of you said it's quite common here. Do you think it's more common in the UAE, in the region, than in other places? And if so, do you think maybe there's some kind of link to ethnicity or to levels of vitamin D or sun exposure, anything like that? Thank you.
Thank you, Rasha. That's an interesting question. And for the last 10 to 12 years, I am practicing here in UAE. So I cannot compare with the practices or the cases which are happening in other parts of the world. But what I have seen through the literature, they are all facing the same issue. It's not to our area, it is global now, it's like a global issue. And what we have seen over the years, the change globally is, like again say, lifestyle changes. We are more into fast food, we are more into instant foods, we are not having our proper sleep pattern and wake pattern. We are inactive, like a sedentary lifestyle. We just have become more lazy as what we were generations before. So what my observation is that it's nothing to do with ethnicity or the region you belong to, it's lifestyle. People from the parts of the world who have more active lifestyle because of their own situation, geographical and lifestyle, when they come here and they adapt to the same lifestyle, they eventually develop PCOS. So the triggering is just the lifestyle, regardless of where you are living and what's your ethnicity.
Thank you. I think we have a similar question from Shaima. She said, thank you for the timely and informative session. What are your insights about environmental factors in addition to lifestyle? So I think the questions are similar.
Yeah, like many of the people, they use the summers of UAE as an excuse for them being inactive, because it's so hot that I cannot go out for walk, I cannot exercise outdoors. So they think that this environmental thing have a role to play on us being inactive. But I mean, like when you want to live healthy, you have to find a way out. It's your life, it's health. It's the most valuable thing. I mean, nobody can give it to you. You have to earn it. So environmental factors, not as such. It's just, I think, yes, summers are hot, but if you want to find a way out, we have so many gyms, we have so many activities, indoor activities here in UAE, that the environment should not be used as an excuse for our inactiveness and thus PCOS.
Okay, thank you. We have another question. Does having fluctuation in I think it's the length of menstrual period, considered irregular period? For example, it is regular like monthly, but then days, I think, keep changing from 6 to 7, sometimes up to 9 days. So is it considered irregular period? That's the question.
Any change in the pattern, like if some person notices that my pattern is not the same every month, and it's like something which is like she sensed it, that's abnormal and needs further workup. And after workup, only then we can find out that there is some underlying pathology behind it, or this is the way that individuals' cycles are.
Okay, we have a question from Dr. Ifat. Do patients need behavioral or psychological support? Do we have a multidisciplinary care in the UAE for these patients?
Yes, and now we are more into developing dedicated clinics for managing PCOS, who will have an endocrinologist, a dietitian, and of course a gynecologist. And I have recommended having a psychologist on board, because now we are suffering from what we call as food addiction. Like I said, the cause is the unhealthy food. And when I tell my patients the treatment is very easy, but on the other hand, very difficult. Very easy, just eat healthy, as simple as that. Very difficult because we have become addicted to these foods. So it's difficult to leave that habit. So psychologists, yes, I truly believe they should be on board in management of PCOS to deal with this polycystic this thing. But we have to think about its cultural aspects, because many people they feel a bit offended that we are being directed to a psychologist because you think that my food habit is so unhealthy and like I'm mentally into it. So we have to be very careful, because we don't want to stigmatize them. We are not judgmental. We want to help them in whatever way.
Okay, thank you very much, Dr. Sawa. I think this has been really very interesting and stimulating discussion. Everyone is interested and asking questions. So if you have questions, please, you can submit to our department or email us, and inshallah we'll forward it to Dr. Saba, and then we'll get the answers for you. So I want to thank you, Dr. Saba, again for accepting our invitation and doing justice to the topic. We hope to see you soon for many more discussions. Thank you very much. I would like to thank also the people who made this webinar possible, the management of our department, our college, and UAE University, who gave us a green light and supported the organization of this webinar. I would also like to thank the organizational and technical team, Dr. Ifat El-Barazi, Ms. Bayan, Ms. Shamsa, Dr. Azhar, and Dr. Mr. Al-Sajir. Thank you so much for all your efforts. I would also like to thank all the participants today. It was a very stimulating discussion from you all. So our next webinar, as this is a monthly webinar, it will be on the 6th April, inshallah. Maybe it will be likely it's going to be during Ramadan. So still it is at 7 p.m. and it's on obesity and metabolic syndrome by Dr. Sarah Saeed. And I think this is a very important topic also, and very timely, given that it will be presented during Ramadan. So thank you very much, everyone. See you next time. Stay safe and keep well. Thank you so much.
Sorry, Dr. Mariam, it's going to be 2 p.m. It's my
2
mistake.
p.m. Okay, okay.
in Ramadan.
Yeah,
Sorry,
because
it's my
of
mistake.
Ramadan. Yeah, I was
Yes, thank you so much.
skeptical about that. Okay, so thank you so much,
Thank you.
everyone. We look forward to seeing you next month, inshallah. We hope you keep attending our sessions. Thank you so much.
Okay, thank you all. Masalam.
Masalam.